Good afternoon, friends, and good to see a decent crowd before the lunch. And when we talk about the future of treatment of osteoarthritis in India, I think we have to think somewhere non-surgical as well. We all know how to proceed the surgery. We have seen all those discussions happening a few minutes back. Now, if you have a patient who is a borderline osteoarthritic patient with the joint space is 50% reduced, patient is having pain, and you in your heart clearly knows that this is not the case for the total knee replacement, the partial knee replacement. What you have to do? You have to offer something, and patients again all kind of physio, all kind of medications which they can take. You have to offer them someone. The patient has come to you for pain relief. And the platelet-rich plasma or the platelets are the go-to cell for us, where we can actually offer them a good pain relief and longer life before they are actually a candidate for the knee replacement or surgical candidate. It's not a new thing. When patients used to have the thrombocytopenia in 1970s, they used to get these injections, IV injections, to raise the level of the platelets. Even now we get for the dengue patients, we give them a PRP or as a platelet concentrate to increase the volume of the platelets in the blood. It started with the sports injuries, cosmetology, and now for the patients who are suffering with the osteoarthritis. Now, how to prepare this platelet-rich plasma? There are two ways to do this. One is single spin, one is double spin. Now, when you do this, it's not an absolute concentrate. Actually, what we do is we increase the concentration, but we reduce the number of absolute platelets in the cell because we damage the platelets by doing the centrifugation. And if you're using a two-spin technique, actually that deforms the shape of the platelet. So the morphology of the platelet is not the same. That leads to a variable outcome. So if I see in my practice 8 years back when I started using the PRP injections, my blood bank in charge, he used to tell me that I'll prepare the PRP for you. But the results were quite variable. Someday he said that I got this much volume, someday he said I got this much volume. And the same thing percolated in my patients as well, that not all the patients were happy with the kind of result we got. Because this PRP is a cellular material and how much platelets we are getting, we can't check for each and every patient that how much concentration we are getting before preparing that particular injection for the patient. What we are talking about is not just the philosophy, it's the science behind this. And if you see, there is a study published in Arthroscopy Journal that when we do the inject the knee with the PRP and we take the follow-up ultrasound, we found there is a significant amount of synovial hypertrophy, there's a significant amount of increase in the vascularity of the synovial membrane, and that leads to probably a better regeneration of the cartilage for these patients, and that's why the effect of this is long-lasting for these patients. Same way the pain relief and the improvement in the function was much better and much longer for these patients as compared to patient who got only medications or the physiotherapy or some hyaluronic acid injection. Now this paper was published in Journal of Arthroplasty, which say that PRP is beneficial. That's definitely, we all know that. But we have no standardization of the process, how to prepare this PRP so that every patient or most of the patients they will get the right kind of result. Simultaneously, there are different companies, different ways to produce this. If we have a standardization, we can compare those results and then we can have a better understanding and better quality of PRP for our patients so that a quality care can be given to almost every patient and we can compare the studies as well. So what are the current challenges? So there is no standard protocol. The final output is insufficient at times. There is no growth factor quantification and that leads to conflicting results. And there is significant amount of pain in the post-op period because they are cellular material. They are containing the WBC and RBC in the concentrate. And the procedure, if you do in my blood bank, which they used to do 8 years back, is a complex procedure, which we used to have doubt about the sterility of the product which came out. So Bocard 2 years back came to me that they have a product which actually promises to have a controlled way or standardized way of producing an injection, which will probably help in most of our patients. So it comes in a sterile kit, so you have to take the sample, 4 ml of blood taken in a vacutainer, so it's a sterile procurement of the sample from the patient. Then you keep the sample for 20 minutes or so that the platelets are activated in that blood. And then you centrifuge for 10 minutes so that the platelet concentrate or the growth factor concentrate is there. It's an acellular material and very easy to take out because it is separate and you can easily just make the tube upside down and take the sample from there. It's completely a sterile procedure. Your technician in your OPD can easily make the material for you. So it's pure, it's ready to inject, it's autologous, it's acellular. That's the key here. GFC is acellular. Whatever we are looking, whether the PRP will help the patient because the platelets will have the transforming growth factor and the IG factor. That will be there in the acellular material. And it's an in vitro platelet activation and minimal operator dependent variation. So your technician can also make the same kind of GFC as you can do or any expert can do it. Because the side effects, the precautions and content is the same for any other intra-articular injections. And because of this acellular material, as compared to my old PRP, the GFC has almost negligible side effects. And second or third day patients are saying that they don't have any pain, any inflammation around the knee joint. That's the beauty of this product. So it's acellular, it's sterile and stable. So suppose the patient is coming today evening and they are in a rush and you want to inject tomorrow morning or maybe 2 days later and they don't have time to stay there for half an hour or 1 hour in your OPD. You can take the sample today and inject tomorrow or in a week's time if you can keep them at 4 degrees centigrade. So that's the stability of the product because it's acellular. So the cells are not going to decay over a period of time. So what is the principal difference? This is an important slide to understand that both are prepared from patient blood. The final outcome is that there is a high concentration of growth factors in the GFC and here there are platelets along with some WBC and RBC. Centrifugation is the first step in the PRP. Here it is the second step because first we are activating the platelets. There is a platelet loss in PRP. Here there is no platelets loss because it's an acellular material. We are just focusing on the growth factors. The process is quite complex in PRP production because we first do a single spin, then take the platelet bullet and then mix it with the poor platelet rich plasma and then prepare a solution. The stability is very good. You can keep it at a room temperature for 8 hours. The results are quite optimum and the number of sessions required are less. And to tell the truth, nowadays I don't inject 3 injections. I give one, I coin the term super GFC. So I take 2 injections and give the single shot because most of our practice is patients are coming from far away places. Calling them 3 times over a period of 3 months is a tough job. And sometimes because of your busy schedule, you are not available on that particular day to inject on that patient. So my colleague is also doing a study in PGI Chandigarh where we are comparing these 2 injections, single shot versus 3 injections, and we are finding a decent result out of this. The pain and inflammation is quite less because they're acellular material and the risk of infection is not there because it's completely sterile packaging through and through. Well, here discuss 2 studies which actually showed good improvement with this. And in the first study, it's a prospective trial of the ONE treatment with growth factor concentrate therapy for its efficacy and safety. So 3 injections were given and they enrolled almost patients who are more than 18 years of age. The standard method of preparation of the GFC. So total 42 patients, 31 were the unilateral knees, 11 were the bilateral knees. So total 53 knees were under evaluation. Overall, if they see that 20 patients were not following the 3 doses, and that was the main issue which I also decided to go for 2 injections in single dose because it's very difficult for the patient to come back for the follow-up, especially when they're staying far away from your clinical practice area. So if you see the patients who are in the different demographic data, I'll just take 2-3 more minutes and compare the Oxford knee score and the visual analog score. It was found that at 6 months, even with patient 1 or 2 doses, were having a good result as far as the pain and the function was concerned. And patients who had 3 doses, the clinic VAS score was significantly low after the end of 6 months, and their Oxford score also improved significantly over a period of 6 months. I'll skip these slides because there's a repetition of what we said. So actually it helped in showing the improvement in the clinical pain score and the functional score of the patient at the end of 6 months and 1 year. And when patients followed all 3 doses, they were much better as compared to patients who had only 1 or 2 doses. The second study is a comparison of the hyaluronic acid versus GFC injection. That's the beauty because we have both injections available in the market, and which one is going to do better for the patient, we have to see that. So it's a multi-center study done on multiple hospitals in India across 6 centers, and the inclusion exclusion criteria is the same as for any intraarticular injections, where we have to just avoid any kind of infection around the knee joint. Preparation is a standard method, and the patients were randomized. So 50-50 patients, both the groups. One patient dropped out of the GFC in the middle, and they studied the VAS score, COOS score, WOMAX score, and the IKDC score. And if you see, all of them are showing significant improvement as compared to the hyaluronic acid with the GFC. So we compare all of them, change it from baseline at 5 months, 8 months, 11 months. Statistically significant improvement in the treatment group versus the control group. So besides knee, nowadays I'm injecting the GFC in other areas as well, like the tennis elbow, plantar fasciitis, post-ACL reconstruction, ankle arthritis, along with the Dr. Agarwal's cocktail. So the advantage is it's a non-surgical treatment for patients where, as a surgeon, you don't feel that surgery is required. It's completely acellular, no platelet loss, excellent stability, safe option, sterile, and a very simple protocol where any of the technician, we train them and they will make it for you in next half an hour or 45 minutes. I thank you, WIROC and the team for inviting me here. It's an excellent venue and excellent arrangement here. Thank you. Any questions if you have, you can ask it. If you have time before lunch.
Thank you, sir.
Thank you.
Now for the next session, which is injuries around the foot and ankle in children, I would like to call upon stage our chairpersons, Dr. Swapnil, Bhise, and Dr. Amin, Shah.
Good afternoon, friends and colleagues. So we have hit the lunch time, but satisfy our appetite, our academic appetite. We have a very interesting session about the pediatric ankle injuries, which is a day-to-day subject for an average general orthopedic surgeons. So are the injuries same as that of the normal, the adult ankle, or what are the loopholes or the tricks in cases of children? So to go through the journey, I would invite the speakers, Dr. Tushar Agarwal, come on the stage, and Dr. Mandar Agashe. Thank you.
Thank you very much, respected Dr. Amin Shah and Dr. Swapnil Bhise. It really is a great sight for me that even in the lunchtime we have a lot of people here. Probably the dim lights, they are hoping for an afternoon siesta, but we are hoping that with our very interesting lectures and the case discussions, we'll have a very good vibrant session in this afternoon. So may I please call upon the first lecture of the talk, so we have started off chronologically. We will be starting with a very young child. We have Dr. Jaideep Dhamele, who will be talking on acute ankle fractures in a very young child. Yeah. And may I also invite the other speakers also on the dais, Dr. Binoti Sheth, Dr. Vikas Basa, Dr. Maulin Shah, and Dr. Mudit Shah and Dr. Viraj Shingade.
Good afternoon, respected chairperson, my dear colleague. My talk is on ankle physeal injury, mechanism of injury and fixation technique in first decade. So everybody knows anatomical classification by the great legend Salter Harris. Type 1, separation of the physis. Type 2 is above the physis. Type 3 is below the physis. Type 4 through physis. And fifth is compression. So it is very important to know the ankle physeal injury, what is the mechanism of injury, because depending upon the mechanism of injury, fracture pattern, you can reduce, close or open. The first is most common is supination inversion injury. You can see here at alteraris type 3 of the fracture, medial malleolus, tubular transverse fracture. Second common is pronation eversion external rotation injury. Third is supination external injury. Here you can see the fracture pattern of the fibula is vertical and tibia is also vertical. Last is supination plantar flexion injury. We go one by one. Supination inversion injury is, you can see the type 3 Salter Harris. So here, this is the shearing force acting at the physeal will require the compression. So there are the two stages. Stage 1, we can see only the swelling, localized swelling. We cannot initiate any fracture on AP view. Stage 2, once the force is more, supination inversion, the complete fibular physeal will separate it and medial malleolus is fracture. You can see here. So we just going with this talk, what are the clinical finding and what are the problem. You can see the local tenderness over the fibular physeal, soft tissue swelling. In the management here only we have basic two things only, support and mobility. You can give the cast for 3 weeks followed by the ankle brace. Stage 2 here, this is the severe pattern of the injury. You can see here the complete fibular physeal is separated, medial malleolus is separated. Here you can see it's type 3 or type 4 fracture. This is a very severe form. This is crushing injury. The prognosis is very poor here. So what stages of the treatment? We want close reduction or open reduction. First we obtain the satisfactory close reduction. This is okay. Everyone can see this is okay. This is adequate, but there is a continuously vertical shear is acting on this. So we want to neutralize that source. So people will use the K wire, but this is not neutralizing the force. The ideal should be the compression force. We wanted transphyseal screw that gives us the compression at the fracture site. So how will you know the reduction of the fracture is achieved anatomical? We wanted any physeal injury, good anatomic reduction. So we do the orthogram intraoperative to know that there is any steps or any other fragment. So how will you know the fracture is united? We follow. We always see the growth arrest line. No need of MRI. You can see the here Park Harris growth arrest line which parallel to the physeal here. Does the fibula require any fixation? Generally, when we reduce the tibia fracture, fibula is automatically reduced. No need of any fixation of the fibula. So this is second most common injury, pronation external rotation injury. You can see here the pathology here. So this is the most common, second most common injury. Everyone can reduce the close, but you can see there is a very soft periosteal fragment and soft tissue avulsion. When we do the close reduction, always there is the interposition of the soft tissue. Close reduction, this case we can manage with the close reduction and long as cast. If they are unstable, always fix with the transphyseal screw. The interposed tissue, you can, I have already told, soft tissue, periosteum or neurovascular bundle. Always check once the close reduction is done that the pulses appear or not. The main aim of the ankle physeal injury we want is satisfactory anatomical reduction. Problem, lot of Salter Harris injury, they inadequate reduction, malunion, growth arrest, angular deformity and late joint problem just like arthritis. So this is a very landmark article. Always do the CT scan whenever there is a suspected ankle physeal injury. On this is a JBJS 2018. With this CT scan, you know the where is the fracture pattern. We want perpendicular to pass the screw on that pattern. So some cases, 13-year male child with left ankle twisting injury. So on this X-ray, what type of Salter injury? Always do the other view also. This is a supination pronation injury. Salter Harris type 3 here looking. We want more view or CT cut. Is the Salter Harris 4. You can see the management will be different. So we did the close reduction, satisfactory reduction we found. So first we always pass the one guide wire exactly center of the epiphysis, hold the reduction with the towel clip. Then we pass the second wire just parallel to posteriorly. You can see here close reduction is done. Then always do the orthogram to know whether the anatomical reduction is achieved. This is a post-op X-ray. 1 year follow-up. There is no growth arrest, post-implant removal, full range of movement. The next case, Salter Harris type 2 injury. We always do the CT scan in ankle physeal injury because some type you can see in AP type 2 and lateral type 4 injury. Manage with the close reduction, same pattern. These are the 1 year follow-up, no growth arrest. This is the 10-year female child. You can see here the fracture is above and fibula fracture is also above, vertical fracture. So we just want whether most of the people will conserve this injury, but this is unstable. Pronation, eversion, external rotation injury. This is the CT scan. You can see both the fragments are very high. So we did the close reduction. This is a post-op X-ray, 3 weeks, 2 months, 9 months. This is another case, 10-year female child. She presented after a week. You can see in AP X-ray, no one can make out any fracture line is there. On lateral, you can do the Salter Harris type 2 injury. We did the CT. You can see on AP, it is a Salter Harris type 3. On lateral, you can see Salter Harris 2. This is where you want to CT. CT will help you to guide your. Last slide, you can see the Mercedes-Benz sign here. The CT scan will play here. How will you pass your screw for planning of the screw placement? Otherwise, the fracture will not compress and not heal. So we did here close reduction as pre-operative plan. This is the post-op X-ray, 4 weeks, 4 year, no growth arrest, full range of movement. This is another case, 13-year female child with medial malleolus 1 week old injury. We tried here close reduction, but close reduction is not possible. So we did the open reduction, passed the 2 screw. This is post-operative X-ray. 1 month, we removed the 3 weeks immobilized with the flap, and then we give the cast shoe. So 1 year, there is no growth arrest. So complication of physeal injury is most common is the growth arrest is partial or complete. Associated fracture type 1 and type 2 develop up to 2 to 39%. Type 3 and type 4, 7 to 50%. Growth arrest can even seen after 2 years. So once we see the fracture is united, we will not call for the follow-up patient. At least minimum 1 year follow-up required for the ankle physeal injury. Take-home message. Diagnosis of the physeal injury, Salter Harris type and mechanism of injury is very important. Triplane fracture has a high risk. Madam will talk on that. CT scan will help to know preoperative planning for the trajectory of the screw. Reduction has to be anatomical as possible. If not closed, don't hesitate to open the fracture. Gap more than 2.5 mm with growth remaining more than 2 years need to be operated. Orthogram always necessary to know the status of the reduction. Strict follow-up. Always see the physeal Harris line, whether the growth arrest is there, and at least 1 year follow for any fracturing. Thank you.
So thank you, Jaideep, for this excellent and excellent overview about ankle fractures. We'll now be going about slightly an older age, which is the adolescent ankle injuries, and these are some very perplexing injuries in a child. So we have Dr. Binoti Sheth who will be explaining to us exactly how to manage these adolescent ankle injuries.
Good afternoon, and thanks first of all Bombay Orthopaedic Society and the viewers and the audience first to attend our session even during lunchtime. So that tells us that you have a good academic appetite. Right, so Jaideep has spoken to you about the physeal injuries in younger children. But almost 7 to 15% of all physeal injuries in adolescents are around ankle area. And this is an age group of 12 to 16 years, who are neither very young child, neither they are adults, and they are in the stage of transition from an immature to mature skeleton. And that is why they are also called as transitional fractures, because they neither behave like child fracture nor do they behave like an adult fracture. And the treatment also is specific and the diagnosis is very particular. And this happens because there is an asymmetric closure of the distal tibia physis during the 18 months period at this particular 12 to 14 years of age. So the physis fuses centrally, then medially, posteriorly, and then laterally, and finally there is full physeal closure. So when the injury occurs, depending upon what is the status of closure of the physis, a particular variety of fracture occurs, and that is peculiar about what we are going to talk about, adolescent ankle fracture. So the common mechanism of injury is external rotation force to a supinated foot, which is a very common sports-related injury. And there are two types of these fracture. One is a juvenile Tillos fracture, which is described after French surgeon Tillos, and this is the one where the fracture involves only the epiphysis. If this fracture line extends into the metaphysis, that is what is called as a triplane fracture. And we'll see this in detail. So Tillos fracture is actually an avulsion of anterior inferior tibiofibular ligament. And this part which is not fused, because this lateral part is the last to fuse, so remaining part of the physis is already fused. So whenever there is an injury and this ligament gets strained, it brings a fracture along with that. A part of the physis avulses, and that leads to a Salter-Harris type 3 fracture, which is called as a telos fracture. So if you see on the X-ray, the remaining physis, where beyond the fracture on the medial side, the physis is already closed, and this part where the fracture occurs, the physis is open. So the diagnosis is better seen on a Mortise view, and it is always better to do a CT scan because that will give you a better definition of about the fracture displacement, and it helps you in surgical planning. So if it's an undisplaced fracture or a very less displaced, less than 2 millimeter, you can treat them conservatively in non-weight bearing above knee cast with knee in about 30 degrees flexion and the foot in a neutral or internal rotation, because as we saw earlier, the mechanism of injury is an external rotation avulsion of the anterior tibiofibular ligament. You're going to reduce by reversing the mechanism. But if the fracture is displaced more than 2 millimeter, then after doing close reduction, you may have to manually reduce the anterolateral fragment. You confirm the reduction by doing an arthrography, and then it's better to fix them by either percutaneous K-wires or screw fixation, because that will give stability to the fracture. Very rarely, if the close reduction fails, sometimes there is interposition of soft tissues or periosteum or neurovascular structure, and you may not get a close reduction by this maneuver. Then you can do an open reduction by an anterior approach with an interval between the extensor digitorum longus and extensor hallucis longus. And again, the fixation with a screw, 4 mm compression screw, would be ideal if it's a large fragment, so that sufficient stability is achieved. Coming to the triplane fracture, it's a very unique type of fracture which appears as Salter-Harris type 3 on AP view, and on lateral view it appears like a Salter-Harris 2. But actually it's a Salter-Harris type 4 fracture, because the fracture plane is in 3 different planes. There is a sagittal fracture, a coronal, and a rotational, and that is why it is called as a triplane fracture. So it appears like this different. So never judge the fracture just on one view, always have AP lateral and then decide that whether it's a triplane fracture or not. And almost 50% are associated with additional fibula fracture. If you see on the top figure, there are these 3 major fragments. You have an anterolateral quadrant of distal tibia epiphysis. You have the medial and posterior portion of the epiphysis in addition to the posterior metaphyseal spike. And the third fragment is in the tibia metaphysis. And it's not just one plane. It's a complicated fracture. And depending upon at what stage of physeal closure this fracture occurs, based on CT, you can have 2-part, 3-part, or 4-part fractures. So again, for diagnosis, you have to do a CT scan, because that will give you an idea about the fracture fragments, the types, where the fragments are displaced. And this is a classical Mercedes-Benz sign which you see on an axial cut, which is very diagnostic of triplane fracture. A 3D reconstruction will help in, again, planning your treatment and knowing the fracture fragments. So coming to treatment principles, again, if it's a non-displaced or very minimally displaced fracture or an extra-articular triplane fracture, then you can do close reduction under anesthesia, and again with traction and internal rotation, and immobilize in a non-weight bearing above knee cast. But a serial follow-up X-ray and CT scan is required to confirm the reduction, and these are very, very rarely if it's a completely undisplaced fracture. Majority of them are more displaced, more than 2 millimeter, and required a thorough, proper close reduction under anesthesia and percutaneous screw fixation. Again, the size and the type of reduction maneuver will depend upon what is the fracture geometry. 4 mm screws are usually passed from medial to lateral or anterior to posterior, or both, based on what is your fracture pattern. Open reduction, if the close reduction is not successful, can be done. If it's a lateral triplane fracture, then enterolateral approach, and if it's a medial triplane, you can do an enteromedial approach. Sometimes in 3 or 4-part fractures where you have a separate big posterior fragment, you may require an additional posterior exposure between flexor hallucis longus and peroneus brevis. If there is an associated fibula fracture, then it may hamper in your reduction maneuvers, and you may have to do fibula plating before contemplating fixation of the triplane fragments. What is the prognosis of this type of fractures? Well, telos fractures, you have good outcome because it's just a small Salter-Harris type 3 fracture involving only the epiphysis. So the risk of growth arrest is less. But if it's a triplane fracture, there are high chances of early arthritis if you don't get your fracture alignment well, joint alignment well reduced, and a close follow-up for growth arrest and angular deformity is important. And we'll see about the more complications in the next talk by Dr. Tushar Agarwal. If I have to give a brief summary of what I talked about, telos and triplane fractures are special ankle fractures in adolescents, known as transitional fractures. You must be aware of this, otherwise you are likely to miss the diagnosis. CT scan is helpful in evaluation of the fracture displacement and planning of your treatment. The goal of treatment is to restore the articular alignment, and if you follow the proper treatment protocol and diagnose and treat them well, then you can expect good result. Thank you so much.
Thank you, madam, for this very succinct talk on adolescent fractures. So now we know that ankle fractures can get complicated. Many a times they are missed, they are neglected, they are treated improperly, and we know that complications can occur. So we have Dr. Tushar Agarwal, who is going to be talking to us about what are the complications of these pediatric ankle fractures and how do we manage them.
So much has been said in the last 16 odd minutes. You know, it has taken us over 15, 18 years of continuous association, Binoti, me, Jaideep, and they had to summarize the entire ankle fracture learning in 8, 10, 12 minutes. So it's very difficult. There is a very famous motivational speaker called Tony Robbins. He says the problem in human being is not what they are capable of doing, but what they won't do in spite of the fact that they are capable of doing. So the complications of ankle fractures occur is in spite of listening to these great talks, in spite of being aware कि ऐसा fracture होता है, first decade the fractures are different, second decade the kids fractures are different, we continue to probably overlook some things. And that is proven by this study which was done by the National Institute of Clinical Excellence. So this is something which is being run in UK, which is like the AOS body. And they've got guidelines for pediatric fractures. From my understanding, they've got guidelines for distal radius fractures, ankle fractures in children, and pediatric shaft femur fractures. And they found that the surgeons were goofing up maximum in the ankle fractures in children. And this they are talking about trained pediatric orthopedic surgeons. So why are we talking about complications in ankle fractures in children? Is because they are bound to occur, because our eyes are not going to see the complication happening, right? So we were found wanting in treatment for ankle fractures, and that's why the rate of complication is higher. Now, this article tells us when the complication is almost a deemed certainty. So if the ankle fracture was a high energy trauma, if the initial displacement was more than 6 millimeters, and if we have delayed the treatment for more than 24 hours, then it's like a deemed complicated ankle fracture. The chances of having complication in this ankle fracture is much higher. And we have to bring the reduction to as little as 1 millimeter. So we should err more on the side of open reduction vis-a-vis the side of close reduction. Now this article tells us that when do we get the final complication. So we have open reduced or we have close reduced and we have missed a displacement of 2 millimeters. Now there are two types of displacement in ankle fractures. One is within the articular surface and the second is at the metaphyseal level. I'll show you with some cases. So you can have what is called as physeal widening. So you have reduced, open or closed, you have fixed it, but the physis is still wider by 3 millimeters. So then you will have what is called as premature physeal closure, and that is specific to ankle fractures in children. There is an incidence of CRPS. I wish to ask Binoti, Mandar and our panelists whether they have seen CRPS, but I believe it will happen to very high energy ankle trauma in children. There is a rare complication called extensor retinaculum syndrome, which we will show you cases of. And if you leave behind angular deformities more than 10 degrees or rotational deformities of more than 5 degrees, then it's very poorly tolerated in ankle fractures. So, an early summary, if you fail to recognize an injury, if you fail to recognize the significance and impact of the injury, then you are bound to undertreat or overtreat. then you will get complication in ankle fracture. Besides, when you have a bad injury to start with, or you delay the treatment. So the margin of error in ankle fracture treatment for all of us is very, very less. So in spite of our talks, this can happen. So what Salter-Harris is this? Now our minds tell us that Salter-Harris 1 and 2 lesser complications, 3 and 4 more complications. But see what is happening here. What will you do for this patient? So is close reduction enough, or I'll open reduce it? So taking from my talk, I open reduced it, and there was a thick tissue, soft tissue interposition at the level of the physis, which we removed. Then you get a very firm endpoint of reduction. Remember, in ankle, you need to get a firm endpoint of reduction. It should be without any force at all, and it should be staying in position without any force. Your fixation tool is only maintaining it, it is not reducing it. If your fixation tool is forcing force reduction of that ankle fracture, you are bound to get complication. This is just an extension of that. So when you get, what do you see in this X-ray? You see a fibular fracture which has happened in the metaphysis. So whenever you see a fibular metaphyseal fracture, it is always a Salter-Harris type 1 and 2 injury in the distal tibia. And what will be the complication? It will always be soft tissue interposition. So in this case, we attempted a force close reduction. And you can see the gap which has remained. That gap leads to the complications in these patients. Okay? Now you see this. There is an anterior gap. Now in this next case, you will see there is an anterior gap which is remaining here. So this anterior gap is what is going to lead to the complication. So in Salter-Harris 1 and 2, you have problems of the persistent gap. Now what is happening here? This is a very famous slide many of us have shown before. The knee is looking up and the foot is looking outside. So you may walk into the casualty and you will look at the X-ray of this patient and not able to make out. So there is a type 1 injury in which the foot has completely externally rotated. So you will miss an ankle fracture in totality. Okay? So how will you identify it? By looking closely at the fibula. So if you have a fibular metaphyseal injury in a child, suspect a type 1, type 2 injury in the distal tibia. Vis-a-vis, when you have a fibular growth plate injury, that means a fibular physeal injury, then you suspect a type 3 and type 4 injury in the distal tibia. I think that's the one message which you should take back from this talk. Okay? Now, isolated fibular fracture in adolescents, that is also causing a lot of complications. So what will happen? Patient is 16 years of age, fibular growth plate closes very late, as a result of which you miss this subtle growth plate injury. So it's like a displaced lateral malleolus. This image you should keep in mind. So if you go back to your clinic, you see a patient who is 15, 16, 17, and you see tenderness at the level of the fibular growth plate, investigate him more, otherwise you are missing a displaced fibular growth plate injury, which can lead to a complication later. So our presumption that Salter-Harris type 1 and 2 are simpler injuries with lesser complication is wrong when it comes to ankle injuries in children. They would need open reduction frequently. We need to remove interposed tissues. The tissue could be nerve and vessel as well. And we require a higher level of awareness, okay, to understand this. Now we come to the injuries which we are trained to understand. Salter-Harris type 3 and type 4. This slide was already shown by Jaideep. And what you do is, you have to do a screw fixation. In spite of us discussing this, the temptation to fix it with a K-wire is always very high, and that would lead to a much higher complication of bony bar formation, which can lead to all these kind of angular deformities and a much more difficult and complex process. Now, some people, in spite of their best abilities, would have neglected ankle fractures. So in these kind of injuries, it's very complex to treat. You can't really leave them alone. So with the help of a JES fixator, we have managed a varus malunion. Similarly, we have managed a malunion in valgus with the help of a JES fixator. So final points is identify your fracture. Fibular growth plate injury means tibial type 3, type 4. Fibular metaphyseal injury means tibial type 1, type 2. Both require aggressive open intervention, exact anatomical reduction. Be aggressive in treatment of ankle fractures in children, as the margin is very less. So they are not easy to treat, but by paying attention, we can prevent unwanted problems. Thanks a lot.
So, thank you, Dr. Tushar Agarwal, for this excellent overview of complications of ankle fractures. So, this is a session on foot and ankle injuries. So, we will now be going towards a bit of foot injuries also in kids. And this will be a more interactive session. We want more audience participation for this. These are slightly more practical cases that we'll deal with. So, we'll start with the first case. This was an 8-year-old boy, a very playful child running around everywhere, was playing in his lawn and had an injury by a small iron nail, a khila, on the plantar aspect of the right foot about 5 months back. This khila was removed. The khila was found to be completely intact, and that penetrating injury healed up completely after about 4 to 5 days. He was asymptomatic till about 7 days prior to his presentation, and now has come with significant swelling and pain over the dorsal aspect of the foot near the 4th metatarsal neck. He now has intermittent fever. He has been treated intermittently by a family physician with antibiotics. Has a swelling over the dorsal aspect of the 4th metatarsal with warmth. So the question is, what can be the cause of the swelling now? Why so late? And what to do now? Do we have someone in the audience? Dr. Mahapatra sir is here, a very senior orthopedic surgeon from Ulhasnagar. So he has a penetrating injury about 5 months back, and he was absolutely asymptomatic for about 5 months. We'll start with our panelist, Dr. Vikas. He comes to you at Ambani Hospital. Yes, sir.
Sometimes what happens, some foreign body goes inside. It remains inside and it is covered with fibrous tissues, and later it gets infected. It may be because of that.
So, any other, yes.
Yeah, I suspect the same. Because after such a long time, coming with the swelling there and pain, so I suspect some infection there.
Correct. So he has presented with all signs of infection. Viraj sir, what do you think he has?
Hello. Yeah, Mandar, the fungal osteomyelitis is very common in our country. So
Correct.
I think that is one of the possibility we should always suspect. And they usually present late as compared to the bacterial one.
Correct. Perfect. So these are all the things which ran through my mind. One of them was foreign body. So this was the X-ray. As you could see, there was some changes around the 4th metatarsal. The MRI showed a significant edema and significant collection, which was from the dorsal going right till the volar aspect. And the MRI consultant said there is something funny. Some artifact is there. A couple of small artifacts are there. And the sonologist, this is an excellent sonologist who gives me all these diagrams. He labeled these foreign bodies. So can someone guess what those foreign bodies are? So there's literature to support this. So what happens is this. So whenever there is a rubber-soled shoe, the penetrating nail goes in and comes out, and that part of that rubber shoe remains in. And these are small particles which are there, and those are the cause for late osteomyelitis and late infection. So whenever we have an injury like this, always remember that it has to pass through that rubber-soled shoe. And that rubber-soled shoe, that small particle, is the thing which is going to cause an issue. The wound heals up very well, and then the child presents with late osteomyelitis and abscesses. There are a lot of literature. So after I found this case and I started preparing for this, there was a lot of series on these sort of rubber retained particles of the rubber-soled shoe in literature. So I expose, you can see that there's this small foreign body there and multiple other small specks of rubber sort of foreign bodies in the wound. And this completely healed up. This was an photo which was sent by WhatsApp, just a hypertrophic scar, but otherwise it has healed completely. Just to take home, always be cognizant of that rubber particle in a penetrating injury. Whenever a child is outdoor, he always has some shoe with him, and that can cause issues in the child. And possibility of late osteomyelitis and abscess formation, especially in kids, is important, and look for and remove all the foreign bodies so as to achieve a good result. We'll now come to the second case. We have Dr. Tushar Agarwal here. This is going to be an extension of some of the things which we discussed till now.
Dr. Mandar, I have a comment.
Yes, doctor.
Suppose, is it like a take-home message, like, whenever there is a penetrating foreign body injury, will the ultrasound at the first instance would help in detecting those rubber material
so
inside?
unfortunately, we do not get many patients in the acute setting. What happens is that there is a nail injury, the wound heals up, and everyone thinks that everything is hunky-dory. If we do get a wound, then better to get an ultrasound done and then and there, so as to remove that small piece which may be inside.
Also, I think sometimes the parents say that the nail has come out, but it was probably the nail had broken also sometimes, and you just don't get the tip of the nail has been inside.
Correct.
All the while. You don't get the full nail because you don't see it.
So the
parents
advantage
say
of the
they have
nail
seen
is that it can be seen on an X-ray.
Correct.
This is the thing which is not seen on an X-ray, and that is what causes issues later on.
Correct. So
So
we
the
should not
ultrasound
always
comes
believe
in-
what the parents say. We should be a little careful of that.
Absolutely.
Also.
Absolutely. Yeah. So we have the next case, again an ankle injury.
So an extension, is this X-ray clear? Because this is a very old X-ray in the era of non-digital format. So it was a 10-year-old male. Now look at the fibular fracture. I kept 4 or 5 times I said. So you have a higher fibular fracture. So what tibia fracture you have? Which Salter Harris? Type 1 or type 2? It will not be type 3. So it's not intra-articular. So then what is happening here? What will we do? So Viraj, we'll start with you.
Yeah, I think on X-ray it appears to be, more of a type 2 injury, at least on X-ray, or whatever, I could guess from this view. But these are the cases, I think, where, as you mentioned in your talk, where we should have the detailed evaluation like CT or to know the anatomy better, because ankle is such an area, it is not like that it is going to remodel like a radius. So we need to have very anatomical reduction and the best possible what we should give. So I think CT scan will be the helpful in particular case.
Aggressive imaging is the message which he is giving.
Yeah.
Vikas, what will you...
And clinically, Tushar, I would also say that these type of injuries, they are more from compartment also. So I think we need to evaluate.
Yeah, fantastic.
Especially I'm talking about this injury, so we should keep in mind that.
And compartment will happen due to?
Mostly because of the very less area involved and the vessels proximity which are there.
Fantastic.
That is the main reason.
So Vikas, now?
Yes, one is compartment syndrome in such type of injuries, and extensive imaging like CT scan is.
So I think very safely say that the clientele which you get and the clientele which Viraj get is completely different, right? Means it's poles opposite. So would it make a difference in the level of imaging? Viraj, would you be very easily be able to advise CT, MR in all your patients with such an ankle fracture?
Yeah, I think for nowadays it is possible. It was not before 10 or 15 years ago, but now since most of the centers, they have the CT scans and we could reduce the cost because of, so I think it is possible.
I think a take home is that CT scan is a must for every ankle injury.
Mudit? You should be careful of the medial side skin condition also. Fantastic. Yeah. Because medially we can see the tibia is there, we should be a little careful. So I'll just quickly now go over what happened to me was this was done in 2008. That's a long time back, right? And I did a close reduction. That time I had not even started reading on ankle injuries in children. I was a pediatric orthopedic surgeon and I thought ये तो थोड़ा horizontal दिख रहा है 5 डिग्री oblique है तब heal हो जाएगा. And एकदम heavy कास्ट वास्ट देखो
so, बच्चा है बर सब भर जाएगा.
हाँ, मैं भी सोच रहा था. In spite of being a pediatric orthopedist, and I was doing X-ray at that time. I was not doing it in a CM control also. Means I was practicing in a setup without CM. The younger guys cannot even imagine ऐसा कुछ हो सकता है. So, and this is what happened. He came to me straight, like after about 7, 8, or maybe 12 years, when he became like 22 years, and this is what the X-ray was. एक्सरे ठीक लग रहा है मतलब Viraj, what do you think he would be having now?
Yeah, I think that is what I mentioned, Tushar, because there is a big difference in distal radius and ankle. So we have to always, this is a classic example that it is not going to remodel. So if you are not going to restore the anatomy, as even Binoti has mentioned, that it should be as accurate as possible, then only you can give. And this, if at this stage, definitely it is going to require some kind of osteotomy, maybe dome-like osteotomy.
What else do you think has happened to him?
So has he come for the deformity of the ankle or has he come for something else? So that is the question.
So that is the question. Now I have taken a foot X-ray, and this is what has happened to his foot. So he was worried about this, and I was worried about कि ये हो क्या गया? What has happened?
It must be the compartment at that time.
And what type of compartment? Anybody has an idea? Okay, what type of compartment? Milind, you want to say something?
Deep compartment is involved mostly. The
Deep compartment, okay. But neurovascular, he is okay. Means he has got no sensory hypoesthesia, no pure motor problem. That's why he came so late, right? Anybody else has any?
So the tendo-Achilles, FHL and FDL are all contracted for him.
So this is a question about how keenly everyone attended Dr. Tushar's lecture, because he had mentioned a line about this condition in his lecture.
So what happened was they developed an extensor retinaculum syndrome of the ankle. And it's okay if we could not recollect, because I have realized he got this while preparing for this lecture. Okay, so many years I treated him, I corrected him, we managed him, but I also... So what is extensor retinaculum syndrome? So it seems from cadaveric dissection that the EHL tendon is very muscular and of a certain shape, and it remains very muscular till very late down, till the top of the extensor retinaculum. So it gets pushed into like this, because if you have an ill-reduced fracture, Salter-Harris type 2 of that level, then you can develop a compartment syndrome purely involving of the EHL, and therefore the FHL overactivity pull the toe into flexion. So this is just to show that don't do forcible close reductions on your patient.
I think one of the key things which Dr. Tushar said was that you have to have a good endpoint to your reduction. It should not be a soft endpoint. A soft endpoint and a springy kind of endpoint means that you are going to have some periosteum, and when there is periosteum, there is also neurovascular structures which can be with it. So you should have a good firm endpoint to your discussion. Yes, Dr. Negi, sir.
And not maintained with force.
Yeah.
You should not be...
Mandar, this is very important. Huh?
Yes, sir.
Somebody like me who is a general orthopedic surgeon, I did a close reduction which wasn't sitting into for the supracondylar humerus. It was sort of forced and held with the K-wires.
Correct.
And finally within 15-20 minutes we ended up opening up the whole thing and the vessel was trapped.
Correct. So anywhere where there is a soft endpoint, always be aware that there can be something between the fracture fragments which is causing that soft endpoint. Alright. So we have Dr. Jaideep Dhamele who will be talking about another case of the foot in children.
So this is the 8-year male child. Lisfranc fracture dislocation is more common in adult. Pediatric is a very, very rare injury. You can see here the 8-year male child, history of fall heavy object over the right foot. He presented in casualty with too much swelling, pain, deformity, and unable to stand and walk, the main concern. You can see on the X-ray here the pulse is palpable but not a feeble. Anyone can recognize this here. You can see the divergent type of Lisfranc. Because Lisfranc diagnosis, partial divergence is very difficult to diagnose in pediatric patient. This is a clinical picture. You can see. So you always do if suspecting any injury in pediatric, AP, lateral and oblique X-ray, because that will give right partial subluxation or dislocation. How will you manage this case? Anyone's opinion or panel? First thing, diagnosis. Is always not a Lisfranc fracture is common, but fracture dislocation is very rare.
So we have Dr. Amin Shah here who has a very, very busy trauma practice, and he must be seeing Lisfrancs a lot. So how will you manage him, sir?
The first and classical thing which I see in Lisfranc is a plantar ecchymosis. Common thing is plantar ecchymosis, and the foot is quite tense. So there can be some reduced movements, and which can also be seen.
So as sir suggested, why we see the plantar ecchymosis first in Lisfranc? What is the mechanism of injury here? So as sir suggested, we'll just go because the force we go from anterior to posteriorly. The first metatarsal, first and second metatarsal, there is no intertarsal ligament is attached. Rest second to fifth, there is intermetatarsal ligament is attached that will hold. Whenever the heavy object or severe plantar flexion will go dislocation. So this is the Lisplank classification. You can see here partial, divergent, convergent or completely shifting. This is this type of type C. So mechanism of injury I suggested someone can fall down from the height with plantar flexion. This is another heavy object fall on the foot. So these are the very landmark article guideline for the Lisplank. What we have to see clinically. First important thing, lot of soft tissue edema, compartment, chances of compartment syndrome. We cannot initiate the pulse. Always do the CT or MR to know the other soft tissue injury because all of the other tarsal bone are cartilaginous. So we did the close reduction. Anyone can comment, this is the acceptable reduction? I need to do the open reduction or which fixation because implant is very important. We need fixation. Viraj?
Yeah, radiologically it appears absolutely good, no doubt about it. I mean, if you can get out of that. But clinically, if you are doubting about a compartment, there is no harm in just giving an additional, because that is the first thing we counsel for any Lisplank injury to the parent, that it may land up with compartments. So there is no harm in giving some just a release incision.
Yes, yes.
So,
always
from that
literature also suggested that you always fix because this is we reduce on the table, but it's not a stable. The first any fracture dislocation, if it is the stability, if there is any associated fracture, we need to fix. So we did the close reduction. We hold reduction with a towel clamp. You can see we pass first K-wire from first metatarsal to medial cuneiform. We pass second cross wire because it's a tank dislocation. Pass the guide wire, hold with the reduction with the 4 mm CC screw. Then we pass from third metatarsal because it's very unstable passing with the two. You can see here, these are the steps and you can see the intraoperatively reduction. Always check the reduction while passing the, is not playing, sorry. We have check on the table. Now it is a stable reduction. Pulse is very good. So these are the post-op X-ray. So we did a close reduction. I am question here, should I open, should I reduce open or is there fixation is adequate? So these are, we just, another, what time we remove the implant in Lisplank fracture? So we remove the K-wire at 5 weeks, given the plaster. And this is the 3 months we remove the implant removal and started mobilization. These are the 2.5 and these are the 1 year follow-up showing good range of movement and 1.6 year follow-up maintaining the transverse and longitudinal arch.
Thank you so much. Jaideep, just the only comment is maybe you can prevent a screw. I mean, you can just use just 2 mm K-wire. I think that should suffice.
So we have think about that K-wire, but that does not give the stability. We think about the growth areas. We want stability and start early mobilization.
I think the important thing also is that the first metatarsal's physis is proximal and the other metatarsals are distal. So you can go towards the base of the second metatarsal, but not towards the first metatarsal. So I think I thank the panelists and yes, last by the chairperson.
One question, in general adult population, there is a very high chance of missing the minimally displaced Lisplanks. I want to know from the pediatric faculty, how common is this minimally displaced Lisplanks injury and what do you give a take-home message as to how to diagnose them?
So that's why I think first we do the AP, lateral and oblique X-ray is very important. If you are suspecting something, anything, you always do the CT or MRI to know about, because the cartilage injury, most common pattern of Lisplank fracture is fracture of the first metatarsal and fracture of the second metatarsal, which is we cannot recognize on AP view. Oblique X-ray can show.
Do you propagate weight bearing, because it's difficult to tell a child?
Always weight bearing, but sir, as literature says, weight bearing is possible. It's not possible for us so much weight.
We are running short of time, so we are running short of time. So thank you very much to the panelists, to the chairpersons, and to the audience who has been here in large numbers, even in the lunchtime. Thank you so much. We'll go to the next session.
Thank you.
Thank you.
Thank you all the speakers for
while the photograph is being taken.